my name is Amanda Goodhew. I'm an audiologist by trade and one of the international clinical trainers with the Interacoustics Academy. And today's webinar is on challenging hearing amplification. So some of those complicated hearing losses, complicated cases that we might come across and how we can improve the hearing aid fitting for those cases. What we'll be going through today is how these individuals with their challenging, complicated losses might present in the clinic, how we can assess clients who have these challenging audiological profiles, and how we can make the most of technology to improve their hearing aid fittings. So how do we sort of see these individuals present in the clinic when they come to see us? When I first started thinking about this topic, the first thing that struck me was, well, actually, how do we define what challenging or complicated or difficult is? Obviously, a really good place to start is always the audiogram. And I've put a few examples up here on the screen. So first of all, we have a reverse sloping loss, which can be quite tricky to fit. Then next one along is a slight asymmetrical loss with a sort of mixed component on the right-hand side there. Sometimes we often see some fluctuations with these mixed losses as well, which can complicate matters further. Ski slope losses. Anybody who's tried to fit a hearing aid to these knows that they can be really, really difficult to get right and to sort of get your patient satisfaction where you want it. You've got all that upward spread of masking from the low frequencies and very sort of little usable hearing in the high frequencies sometimes. So there's this sharply sloping nature of the loss as well can be very difficult. And the last one I've got here is an asymmetry. So we've got normal hearing on the right side and a unilateral loss on the left side. Quite a significant asymmetry here. But you could also be considering a bilateral asymmetrical loss where maybe that right ear also had a degree of hearing loss as well. And obviously the left could be a lot worse too, which can complicate matters. Then there's more than just the audiogram. And there's a lot of other aspects of somebody's audiological profile that it's really important that we can consider. So we might be thinking about whether there's an element of recruitment. We might want to investigate the particular pathology behind a hearing loss. Some of those pathologies go hand in hand with fluctuations. We might be dealing with dead regions that aren't immediately apparent just by looking at the audiogram. Obviously, tinnitus patients have lots of complexities as well. I actually asked around some colleagues when I was preparing this webinar, and a really popular sort of topic was actually patients who've experienced significant auditory deprivation, actually trying to rehabilitate them. People were telling me that they found really, really challenging, probably the most difficult of all. Auditory processing difficulties, whether that's with sort of secondary to a hearing loss or in isolation, they can be very difficult cases to manage. And I've also put perceived asymmetry on the screen here because it's not always about the audiological profile in terms of the audiogram, but actually what a patient is experiencing can be quite different. And we'll go into a bit more detail about that later. So how can we best assess clients who have these challenging audiological profiles? First of all, I think it's really important to bear in mind that it's not always obvious whether somebody is difficult just by walking through the door, and it's not always obvious by looking at their audiogram whether they're going to be tricky or complicated or challenging. A really thorough evaluation is the best thing that we can do to try and explore all the areas of their hearing loss and their profile, and really going beyond the audiogram, looking into how their hearing loss manifests itself and the pathology behind it, etc., is really important in establishing the fullest picture that we possibly can. Managing expectations and counseling is really, really key. Well, I think with any audiology patient or client, but never more so than with somebody who's got sort of added complexities and complications. I firmly believe that managing those expectations actually starts before you've even performed audiometry, and certainly before you fitted a hearing aid. So there's a lot to think about before we really even get started. I think this quote from Beck that came about in 2013 is really quite a nice highlight as to what we should be, why we should be going beyond the audiogram. You know, really, we need to remember it shouldn't serve as the primary and certainly not the only foundation that we use to make decisions about hearing aids, hearing aid features, how we counsel. There's so much more that we need to be bearing in mind. So what can we do that goes beyond the audiogram? In terms of actual tests that accompany our audiometry, there's a whole host, and the ones that I put up on the screen now are by no means, an exhaustive selection. There's plenty more that I could go on and on and on about for forever and a day. But I'm going to go through these ones because I think they're quite an interesting selection, and they cover a range of different sort of pathologies and situations that you might encounter. So the 10 test is a really nice test to investigate whether there are dead regions present. Now, dead regions are not always immediately apparent. So what we often have is this situation called off-frequency listening, where, and you can see on the diagram in front of you at the moment, we've got our outer hair cells present, but around that 2 kilohertz region, the inner hair cells and the auditory nerve fibers are absent or not working. However, that 1.5 kilohertz sort of line that's very close to 2 kilohertz can do a little bit of the listening instead. And I've just got a little video, a sort of schematic that demonstrates that here, that hopefully will work for. Oh, let's go back to that. I'll just press play. Hang on. There we go. So you'll see the traveling wave appear in just a moment. This is for 2 kilohertz, and we can see the spike of that lines up with the 2 kilohertz where the inner hair cells should be, but where the dead region is. But actually the edge of that traveling wave is being caught by 1.5 kilohertz, which is then being stimulated. So when we're doing pure tone audiometry, we might be presenting 2 kilohertz and recording a response there, but whether that response is truly representative of what 2 kilohertz is doing on the basilar membrane, or whether that's coming from some of this off-frequency listening, isn't immediately apparent. So the characteristics for sort of investigating dead regions is when we're looking at a threshold to typically above 70 dB. Steeply sloping losses are a good indicator that it might be something to investigate. Poor speech discrimination ability, and that goes hand in hand with sort of distortion of sound. And that's I think hopefully obvious from that previous diagram where, if you've got 1.5 kilohertz having to try and transmit what it can hear from 1.5 kilohertz, but also a neighboring frequency, there's a lot more being asked of those auditory nerve fibers, which is where we get this distortion. There's a lot of resources on the Academy website about the 10 test, so I'm not going to go into the detail of it. I don't want to reinvent the wheel. We've got some quick guide videos, which I've just sort of demonstrated on the screen at the moment, but we also have a lot more detail in 2 of our webinars. One is called Advanced Tests, and the other one is titled Tests Beyond the Audiogram, which can influence hearing aid feature selection. And they all go into a lot more detail about the 10 test and dead regions and off-frequency listening, so I'd recommend that if you're particularly interested in this topic. The next test that we're going to have a quick chat about here is the ABLB test. This stands for Alternate Binaural Loudness Balance. And this is a test that looks into recruitment, but is particularly useful if you're considering retrocochlear pathologies. So it's for asymmetrical losses, and it's essentially a loudness perception balancing task. That's what the patient has to do, is balance the loudness of the sound from one ear to the other. The results sort of demonstrate the dynamic range of each ear, and they're displayed on a laddergram or a ladder chart, which I will show you what it looks like just now. There we go. So we've got 3 different scenarios in front of us here. On the left-hand side, we've got what is basically a typical cochlear loss in the left ear, sensorineural loss in the left ear. And the right ear is our normal hearing ear. And you can see that in this instance, we do have recruitment, which is what we do expect with a cochlear loss. The same range of loudness is being sort of squashed into a smaller dynamic range, essentially, on that left ear than the same range on the right ear. In the middle, we've got a situation where there's no recruitment, so the range is the same. It's still an asymmetrical loss because it's at a different sort of level. That loudness is perceived at a different level on the left and the right, but the range at which it spreads which it spans is the same for each ear. And on the right-hand side, we've actually got a very different scenario. So again, we've got a range on the right ear and a very different range on the left ear, which is actually sort of expanded. So that person's loudness perception is spread over a wider dynamic range rather than a reduced dynamic range. And this is often called decruitment. With the middle and the right-hand side case where there's no recruitment or decruitment, that's a possible indicator of retrocochlear pathology. But even for the sort of the left-hand demonstration where there's a sort of normal amount of recruitment and what we would then assume indicates a sensory neural cochlear loss, is quite a nice demonstration of how that person's recruitment is actually manifesting itself for them. And that can be really useful for counseling and managing their dynamic range and how their hearing aid is performing. Again, we've got a lot more detail about the ABLB test in the advanced tests webinar, and that one also goes into the CC test, which is another useful one for retrocochlear losses. Next up on my list is speech testing. Obviously, we can do that in both noise, we can do ear specific. The reason behind performing speech testing is quite nicely demonstrated by this statement from the British Society of Audiology, which is that we know there really is a poor correlation between sort of the audiogram and our actual difficulty understanding speech and background noise in particular. We're not really able to extrapolate one from the other. So we do need to actually sort of perform speech testing to establish again for each individual what the situation looks like. There are some considerations for speech testing. So which type of test you use, there are many, many out there. Your method of delivering, and this is what I mean by which transducer you use. Are you using transducers like inserts or headphones? Are you doing a binaural test? Are you doing ear specific? Free field allows you to introduce some background noise. And in that situation, you can think about, for an asymmetrical loss, for instance, where you position the speech versus where you position the noise. And that's quite important to bear in mind in terms of what you're trying to assess and what you're trying to establish. The interpretation, that can also vary depending on what you're trying to establish. It might be that you're looking for a threshold. It might be that you're looking for speech discrimination. It might be that you're just looking for detection, understanding. There's a whole range of complexities that we can investigate with speech testing. And again, I think the clinical question needs to drive that on an individual case basis. Just a quick note about retrocochlear pathologies. This can be quite an interesting one. For a lot of speech testing, we're typically reducing the level of the speech to try and work out how somebody manages when it gets quieter and quieter, or we're increasing the amount of noise to reduce the signal to noise ratio. For retrocochlear pathologies, it can be quite interesting to actually make the speech louder and see if that sort of overloads the system essentially, and do their scores deteriorate. With a straightforward loss, we would expect scores to improve as we make the signal, the stimulus, the speech louder. But for retrocochlear pathologies, you can often see that actually it becomes more difficult because we are, as I say, overloading the system and things are then getting distorted. And that can be quite an interesting guide as to whether you then do go down the hearing aid route, because obviously that amplification might then just end up being distorted. And I just want to mention the quick SIN test here. This is a very, very easy, quick way of performing speech and noise testing. And again, we have a lot more detail on that on the webinar, which is the tests beyond the audiogram, title. So I'm not going to sort of, again, reinvent the wheel and go into more detail on that. There's lots of resources out there, but it's a really nice, quick way of getting it done, because I think speech testing can sometimes seem quite daunting with the amount of time and resources it takes up. Comfortable loudness levels. These can be quite useful in establishing somebody's dynamic range. So I think it's really important that we make our instructions very clear. This is the sort of guidance, again, from the British Society of Audiology procedure protocol. It's really important that the patient knows it's not about a tolerance test. It's not about withstanding the loudness as much as possible or as loud as possible. It's about the kind of the reverse of the threshold. It's the point at which it becomes just uncomfortable. And because there are some considerations that we need to bear in mind for uncomfortable loudness level testing. Tinnitus and hyperacusis patients, probably not recommended because you can really trigger their symptoms. There's also the potential for threshold shift. So I know many clinics will only do maybe 1 or 2 frequencies in each ear, or they might do, say, 1 kilohertz and 4 kilohertz in one ear and 2 and 0.5 in the other, so that if the patient does not understand the instructions properly, they aren't sitting there and bearing through quite so much presentation, which could then cause a threshold shift across the full range. So that's an interesting one to bear in mind. In terms of the interpretation and the utility of uncomfortable loudness levels, as I said, it's useful for establishing somebody's dynamic range and can give you an indication about recruitment. And it's really useful for counseling. And we'll talk a little bit more about how we can display these visually later using the visible speech mapping screen, which is just appeared on the screen in front of you. You can use this to demonstrate somebody's particular dynamic range or their usable area and demonstrate how, the hearing aid is going to work within that. But as I say, we'll come on to that in a little bit more detail later in the presentation. The acceptable noise level test. This is a really great tool for predicting how well somebody will manage with amplification. So the way that it works, you establish that person's most comfortable level for listening to a passage of speech, and then you establish a comfortable level of background noise to accompany that passage of speech. The difference between the two is your acceptable noise level. A score of under 8 dB is generally a good predictor that they will manage well with amplification, they will manage well with the noise, and a score of over 12 dB is generally considered a poor predictor. This test can go really, really nicely hand in hand with speech intelligibility scores. And again, in the Tests Beyond the Audiogram webinar, there's a really nice demonstration of how the two go hand in hand with some indications as to who is going to manage well, who is going to struggle. And this information can guide sort of where you set up noise reduction algorithms on the hearing aid, whether you need to consider assistive listening devices, whether a hearing aid is appropriate or not for that particular person. So it can really guide a lot of where you then progress down the rehabilitation route with that particular patient. Now, precision PTA is not exactly a specific test that you can load up in your audiogram, in your audiometer. But there was an interesting study published recently which looked into tinnitus patients. So they took 106 tinnitus patients who had ostensibly normal audiograms. So using the standard frequencies, everything looked absolutely fine. But what they did is perform this precision PTA centered at the individual's tinnitus frequency. So they worked out where their tinnitus was present and did a very sort of fine-tuned pure tone audiogram around there. They found that 49% actually had a very sharply notched hearing loss that wasn't otherwise apparent by just testing the standard audiometric frequencies. And, we know when we're testing OAEs, for instance, particularly DP OAEs, we're looking at usually a sort of an outer hair cell function or dysfunction if those OAEs are reduced. And in this case, they actually found that 13 of the subjects with that sharply notched hearing loss, they had completely normal OAEs. So on the face of a very standard basic audiometric sort of test battery, which was, pure tone audiogram at the standard frequencies and DPOE testings, everything did look completely normal. And even with that sharply notched hearing loss, the OAEs looked completely normal. So whether that is to do with sort of the frequency specificity, or whether we're then considering a sort of an inner hair cell dysfunction situation, which links back to the dead regions that I was talking about, is again worth doing that further testing and that sort of more investigations to look into what exactly is going on underneath that. I think this is quite interesting in terms of considering whether we are testing enough frequencies, either within the standard frequencies that we know, or also the high frequencies, which brings me on to my next one, which is high frequency audiometry. Now, we know that technology in terms of hearing aids is evolving, and we're going to much higher frequencies with hearing aids. So we obviously now need to start testing that as well, and that's really important. But in terms of the utility of the assessment of high frequency audiometry, I've already mentioned those tinnitus patients, investigating whether that's where they have a notched hearing loss that isn't immediately apparent, looking at sort of dead regions as well. For me, two of the main really important things that we can use high frequency audiometry for are ototoxicity monitoring. We know that it's the extended high frequency range where we first start to see the effects of ototoxicity medications, even before that appears on OAEs. So, doing those extended high frequencies is really, really important for that cohort. But early intervention is such a big thing at the moment. We're becoming increasingly aware of the link between cognitive decline and hearing loss, and how, so many people do actually leave it later and later and later before they're willing to admit they have a hearing loss or accept hearing aids or rehabilitation of whatever format. There's a lot of discussions around the world about introducing screening at, say, 65s, just like we have a lot of newborn hearing screening around the world, as a way of starting to detect hearing loss earlier and earlier as possible, so that we can then put into place the intervention at the appropriate moment to try and stave off that cognitive decline. Moving on, how can we really make the most of technology to improve the hearing aid fitting? Well, the tests that I've already mentioned are obviously all part of how we use technology at the assessment stage. And I've mentioned high frequency audiometry already. Touched briefly on the importance of high frequency work in terms of hearing aids and amplification, and how the future trajectory is very definitely higher frequencies and how they can work within the hearing aids to best effect. I think a lot of it boils down to patient satisfaction. However, we know that these ultra high frequencies really contribute to the naturalness of sound, even if they aren't directly audible cues. They can really add a lot to directionality and also music quality. And those are the things that people come into a clinic saying, complaining about, or not satisfied with. So if we can improve those areas of their amplification, then their patient satisfaction rates will hopefully increase. We're now at a place where we can do audiometry up to 20 kilohertz. REM allows us to go up to 16 kilohertz. Obviously, there are some slight restrictions with that in terms of which signal we have available and the bandwidth that ISTS can go up to. Alternative signals are available that allow you to investigate those higher frequencies. But again, there's a need for development across all areas of audiology to start making these ultra high frequencies work for us. And we can also go up to 16 kilohertz with RECD and with our hip measurement, so that we can see what the hearing aid is doing, which is really important. Hearing aid technology is worth mentioning at this point in time. I've already touched on things like noise reduction settings in terms of thinking about the acceptable noise level test. Directional microphones can be really, really useful if you've got asymmetrical losses. Actually setting those up and using different programs and different settings for different environments can be super helpful. Frequency lowering technology we'll come on to in a little bit more detail in a moment. But it's really worth remembering that assistive listening devices have a huge part to play, whether that's with or without a hearing aid. And I put personal FM systems on here because I did mention auditory processing earlier, and the typical sort of recommendation for somebody who's struggling with auditory processing skills, but in the absence of a hearing loss that could be aided, personal FM systems are really great at overcoming that sort of background noise, distance, difficulties, which can improve the signal to noise sort of ratio for those individuals. Now, counselling, obviously the sort of title of this section is how can technology help improve the hearing aid fitting? But I want to touch on counselling because I feel that counselling is not exclusive to technology, and actually the two need to go hand in hand and can go hand in hand really nicely. With any patient, it's always a little bit of a journey. With more complicated losses, more challenging profiles, it's definitely an element of trial and error is going to be there. We're rarely going to get it right first time round. Person-centered care is another sort of buzzword and hot topic at the moment, but there's a lot of evidence supporting that. You know, we know that people are more satisfied if they feel that they've shared the journey and the experience with their clinician rather than being dictated to or talked at. And involving loved ones. You know, hearing loss and hearing aids are, well, a hearing aid is only ever a hearing aid. It's never a cure. It's never a fix. The communication tactics that go with that are so important. And if we can involve loved ones and caregivers and, you know, people who are around our patient on a day-to-day basis to do their bit, then the outcomes will be so much better. And I think it's all about personalizing the experience. That's so important. Again, this is all about patient satisfaction. That's how we get happy patients. So technology and counseling, as I say, I think they can go hand in hand. And I think there's been a lot of developments to try and make sure that technology does work for counseling. There's a few sort of examples that I want to mention here. The sound studio is a fantastic way of setting up a speaker array so that you can demonstrate the real world in the clinic, developing that kind of patient rapport and understanding the problems that they might encounter without them having to necessarily go away and try and report back is really great if you can have that set up. The patient monitor screen allows you to demonstrate their audiogram in a really clean, clear way. The listen to feature, so this is the listen to probe mic or the listen to coupler feature. I think this is a fantastic tool. It allows you as the clinician to listen to what the hearing aid is doing. So, you know, anybody who's tried to deal with a tricky follow-up will know that patients don't always find the language very easy to grasp. They don't necessarily find it easy to work out what words the terminology they need to use to describe what they do or don't like about their hearing aid. A lot of these people are very new to audiology, and whilst we may have been doing it for forever and a day, what we think of as the word tinny, that might not be a descriptor that immediately comes to mind to a patient. So for you as the clinician to have the ability to listen to their hearing aids and to know what they're trying to explain, I think that's a great way of building rapport and a great way of then improving sort of fine-tuning and making adjustments. And again, I think it helps that patient, that client to feel really involved. And again, it's about that sharing the experience that I mentioned a minute ago. This is also a great tool for allowing loved ones or parents of children or caregivers to listen to the hearing aid so that they know what it's doing, and then they know either the limitations of it or where their role can become involved. The big one on the screen here is visible speech mapping, and we're going to go into that in a bit more detail just now. So visible speech mapping is a module within the software that allows you to really see and hear and feel the performance of the hearing aid. It's a great method of sort of educating, informing, and involving parents, patients, loved ones, caregivers in the experience of what the hearing aid is doing. It's both a dynamic fitting tool, so if you perform percentile analysis, this is where you might do that, but it's also a counseling tool wrapped up in one. So this is an example of the visible speech mapping screen, which we've already seen already today. But the way you can set it up is to have it showing the aided situation versus the unaided situation for the same ear. Or you could have it demonstrate left versus right, which is really useful for those asymmetrical losses. In visible speech mapping, you can demonstrate the live voice. So you could take the caregiver or the loved one, wife, husband, parent, whoever has accompanied the patient, and use their live voice and demonstrate how the hearing aid works with that. That's so much more useful than our own voice because they're not going to be listening to the clinician once they've walked out of the clinic. And I think that then helps to demonstrate how the hearing aid is actually working with, a familiar speech sound. In visible speech mapping, you can demonstrate the dynamic range and the usable area. At the bottom, that the darker line is the audiometric threshold, and the darker line at the top is their uncomfortable loudness levels. So if somebody does have a particularly small dynamic range, then it's a really sort of nice way of actually explaining that and demonstrating it. And I really like this view better than I like an audiogram. So I find that an audiogram, to a lot of lay people, or, you know, people who are not familiar with audiology, they find the upside down nature of the audiogram a little confusing. I think when we flip it this way round, it helps to make a lot more sense to people. You can make adjustments to the hearing aids and see the effects of those adjustments live in visible speech mapping. And that's really nice for doing kind of comparisons before and afters. And that can help explain why something does work well or doesn't work well, or why something might be better than another for that particular patient. And we've got our counseling overlays here. So in this particular image, it's the pictures, the images, but you could also have the speech banana on there as well to demonstrate sort of how that relates to that particular person's loss, and also what their hearing aid is doing. So let's think a little bit about those audiograms that I was demonstrating to you earlier. We'll take the reverse sloping losses here. And this next section of the presentation is how kind of visible speech mapping can really work for us, as well as a bit of sort of clinical considerations, what we need to do for these particular cases. So for a reverse sloping loss, the typical thing that we need to bear in mind is whether there's actually enough high frequency gain. Now, you might look at the audiogram and go, well, they've got fantastic high-frequency hearing. We don't need to give them any amplification. But with this type of loss, typically you're not going to have a vented mold. You're going to be doing with an occluded mold. With the upward spread of masking for the amplification, the amount of amplification you need to give those low and mid frequencies, chances are that that's going to affect how clearly those high frequencies then come through. And that patient is going to lose the benefit of their natural high frequencies. Giving them potentially an extra 10 to 15 dB might be essential to really get them to a point where they can hear those high frequency, really important high frequency speech sounds clearly. But with invisible speech mapping, this is where you can work with that particular individual to sort of optimize the fitting and get it just right for them. Now, ski slope losses and dead regions. So in this instance, it's really important we kind of get the basics right first and foremost. So the acoustical properties of the hearing aid, vents, open fittings, receiver and canal aids, whatever it is that you're sort of going for. I think it's so important that the fundamentals are right first and foremost. And you can be creative with these losses. You know, I remember seeing a case that an old colleague of mine saw. The patient just couldn't get on with his hearing aids. It was a much more steeply sloping loss than the example that's on the screen at the moment. And it just was getting awful headaches from the amount of amplification that was going into the high frequencies. And he just refused to wear his hearing aids. So actually what they did was program a different audiogram. It's obviously not the sort of recommended procedure, but for him, he was much happier with an audiogram that essentially mimicked much better thresholds in the high frequencies, and he was then happier wearing his hearing aids. And in that instance, it was very much a case of it's, better that than nothing. So you can be quite creative with how you sort of set everything up for an individual. But the main kind of hearing aid feature that I want to mention at this point is frequency lowering technology, which has been a huge development in recent years. As it's developed, we've become increasingly aware of the need to verify our frequency lowering settings. So it's not necessarily enough to just switch it on and send somebody on their way. We need to actually make sure that it is doing what we want it to do. There will be a huge element of personal preference to this as well. For patients who've had existing hearing aids without frequency lowering, it can be quite an adjustment for them. Auditory deprivation can influence this, whether you've got asymmetries and how you set up frequency lowering for those individuals can be a very personal sort of preference can become involved there. But I've got a video on this next slide that demonstrates frequency lowering in action. What we have here is visible speech mapping. We have the unaided scenario on the left-hand side of the screen and the aided scenario on the right-hand side of the screen for the same ear. And you'll see in a moment the introduction of a stimulus. So kind of like a hissing, but it's a And you're not going to hear it. It's a silent video, but you'll see it appear in just a moment. So to start with, there's no frequency lowering on this video whatsoever. Let's get it going. No frequency lowering on whatsoever at the moment, but you can see there's obviously a big difference between the unaided and the aided situation. But in this instance, that person's not hearing that stimulus. Now frequency lowering has been switched on, and you can see that that stimulus starts to move into their usable area. It's now becoming audible. We might then want to strengthen it according to the protocols that are out there to get it into the right region for that particular person. And then we might do our further fine-tuning within visible speech mapping to get those settings right for the individual. So that's just a nice demonstration of frequency lowering verification in action. And again, we do have a webinar that goes through this in much more detail. So you're welcome to have a look into that. I think it's called something like verification of advanced hearing aid features. So the next type of hearing loss that I want to mention is the asymmetries, and I've combined mixed losses in here as well because I do think that they often go hand in hand. There's a whole array of technological options available for dealing with asymmetrical losses and mixed losses. We might be considering bone anchored devices, bone conduction devices, cross aids, bicross aids, no aids, one aid, two aids. The list is almost endless. If you are fitting behind the ear hearing aids, or well, not behind the ear, but digital hearing aids that require verification, I think it's really important that we aim for a fused binaural image for these asymmetrical losses. We can get very focused on matching to targets, but it's important that we're not too afraid of veering away from those targets if we need to get the best sound quality for the individual. There's no point in over-amplifying the bad ear just to match it to target when it's then just going to distort and, sort of give quite a confused image between the bad ear and the good ear. Again, we're going to be dealing with a lot of individual variability, and, we don't really know quite how the brain is ever going to interpret two completely different stimuli from each ear. Letting the good ear do the hard work is generally a really good starting point. Get the good ear right, if you're amplifying it, get that one right, make sure that's set up. Then if you want to introduce a second hearing aid, you can do so knowing whether you're detracting from the good ear or whether you're adding some benefit. I think it's really important that we never say never as well. Audiologists are typically very good at trying to predict the outcome of any particular given case, regardless of, anything beyond the audiogram. But actually, for some people, a second hearing aid is exactly the right thing. For others, it's not going to do them any good. And I think it's important that you remember what the patient is looking for. Do they want a sensation of sound? Do they want clear audibility? Are they not too bothered about audibility, but they want to feel balanced? There are reports in the literature of cases where people feel insecure without having a hearing aid on each ear, or feel insecure without having a hearing aid on a completely dead ear, but they just want some kind of sensation of balance. And if you've, sort of done your preparation earlier on at the assessment stage, hopefully you'll know what that particular person's motivations and desires and wishes are, so that you can do the work with them. And again, sharing the experience is really important to get towards the outcome that they desire. I mentioned earlier perception of asymmetry, I think, and this is an interesting one. Again, there are reports in the literature of patients with very symmetrical losses, but who feel that there is much more of an asymmetry. And there are also reports of patients who've never worn a hearing aid in one ear because somebody told them that it was a dead ear, or they got the message somehow that it was a dead ear. And actually their hearing loss was quite symmetrical in both sides. So, what somebody says and what they perceive and what they experience versus the audiogram can again be quite variable. How you then rehabilitate that can depend on what they're perceiving as much as what they're presenting with. It's very much a work in progress. It's that joint shared experience. And again, visible speech mapping is the place where you can make these fine-tuning adjustments and work towards the best balanced sound that particular person wants. So that's a lot to do for these complicated losses, and obviously that all takes time. So efficiency savings where we can find them are really important. And I just want to highlight a few features of the Affinity Compact, which was released just recently. It's really nice to see a system that covers the full sort of client journey, rather than having to move from one system to another and transfer data from one sort of piece of equipment to another, one system to another. That makes it a much smoother sort of process, a much more efficient process. The ambient noise monitor is a feature which has been introduced to ensure accurate audiometry. So this basically allows you to see whether the ambient noise around the patient is at an appropriate level whilst you're performing testing. This is really useful for, as I said, ensuring accurate audiometry, which can then hopefully reduce the amount of retesting that's needed in the future. If somebody does report a lack of satisfaction, you can feel confident in your audiometry in the first place. But also for home visits, domiciliary visits, or going out into the field where you maybe don't have a typical test booth or soundproofing features around you. Complex or complicated hearing losses, they often have other complexities which might restrict their ability to come to a clinic and come to a hospital. If we're then offering home visits, it's really nice to see a feature that ensures sort of accuracy in that environment, rather than limiting them in terms of the audiological care that they receive. The delta values feature is a nice way of ensuring that you get the best match to target in the quickest time possible. So that just demonstrates how far away you are in a numerical value from your target, and you can then hop back to your hearing aid software and increase or decrease the right amount and hopefully get the best match to target in the quickest time. I've already mentioned the listen to probe mic, listen to coupler feature. I think this has huge potential to reduce the number of kind of follow-ups. Again, if you can get the settings right, if you can take on board the individual's feedback and concerns and comments by listening to it rather than having to rely on sometimes very vague feedback, you can hopefully improve their amplification settings in the quickest time possible, and reduce the likelihood of them having to come back again and again and again. The hearing aid transition test is another really nice feature. This allows you to move a patient from one hearing aid to another whilst retaining the audibility settings that they like. I think this is great if you're introducing maybe another type of hearing aid to see if they do sort of better with that, or you want to add introduce them to another hearing aid that has different features, but actually you've spent a lot of time fine-tuning their audibility settings and getting it as right as possible. You don't necessarily want to have to start from scratch all over again. So that's a really nice feature which hopefully reduces again sort of the time taken and improves efficiency. That is pretty much all I wanted to say. I think for me, complicated losses have often been the preserve of major hospitals and clinics, but I hope I've given you a bit of a taste as to how technology can improve what we can do with these individuals and how we can manage these cases, and that can be accessible to all clinicians and all setups rather than just specialist hospitals, for instance. So if you do have any questions, I'd be very happy to hear those now. Otherwise, this webinar will be available in due course on the Interacoustics Academy website for you to have a look back at a later time. Thank you very much.
We've got a question coming in, Amanda, from Dave Spadell. So, hi, Dave. Hopefully you're enjoying the end of autumn over there in the USA. His question is there a way to illustrate the sound studio from the Affinity?
There is a sort of a schematic demo of it. There is. I would guide you towards our product management team who can tell you a bit more detail about that, but there is definitely a sort of a demonstration of it, and you can then sort of, it demonstrates at least the software side of it so that you can then play around with it and see how it would work in a live scenario. Absolutely. That is a feature that's available for sure. If anybody does have any other questions that they'd like to send our way after today, or if you are watching this webinar back at a later time, please do feel free to ping them over to us. We always like to receive them, and we'll do our best to answer them to the best of our ability.
Oh, so Dave's got a follow-up question for you.
Sure.
His question is there any figure on how frequently patients exhibit the need for 10 test?
I don't think there's a particular figure as such. I honestly don't know the answer to that. I can certainly look into it and get back to you. I think, let me just whiz you all the way back to where we were before. I think it's difficult because it's quite an individual thing, as is everything in audiology. The sort of the indications are when your threshold is over 70 dBHL, if there's a steeply sloping hearing loss, if somebody's reporting poor speech discrimination, or you've measured that, and whether they're struggling with distortion or they report distortion. And you can sort of have any combination of those. So in terms of whether there's figures and data as to whether, to how often that's sort of combination appears, I don't know off the top of my head, but it's certainly worth me going and having a look into. The paper by Moore might go into that in a bit more detail as well. But I think, it's the typical sort of indication is when you're up at 70 dBHL, you're likely to be having that off-frequency listening, and that's when you should start considering that. But I don't know what the prevalence of it is, and off the top of my head.
Yeah, and I think that's what Dave is making a reference to there. He's making a follow-up with that, saying that it's his impression that it's something that's probably overlooked very often.
Yeah, I think so.
Absolutely.
I think a lot of people assume dead regions appear at about 100 dBHL, and that if you're sort of recording a threshold or something is not recordable there, then, they can't hear anything at that point. But actually, because we know that off-frequency listening can take place, with the traveling wave being much broader than the frequency specificity of the inner hair cells, that's where it's potentially got a huge amount more utility than we realize at the moment, or that it's actually being used for.
And we've got a final question before we close our webinar for today, that's coming again from the USA, from Sherman. His question is, since many audiologists are pressed for time with respect to your discussion about recruitment testing using the ABLB, wouldn't we establish the presence of recruitment by measuring accurate UCLs? Absolutely.
I think the ABLB is useful for asymmetrical losses. So you need to have an asymmetry to use that. So that, if you've got a bilateral loss that's not appropriate in those indication. I think the ABLB was designed more to investigate whether there was a retrocochlear pathology and whether this recruitment or lack of recruitment indicated a retrocochlear pathology. Obviously, if it doesn't, then you've got some indication of that patient's dynamic range, and maybe that could then reduce the need to do uncomfortable loudness levels instead. It is only a sort of a couple of minutes test, and no one of these really has high sort of specificity in isolation. So a lot of them, need to be considered as part of a test battery for sure. What I was sort of trying to do today is give you an idea of to what the options are available out there, and to encourage people to think beyond the audiogram. But certainly if you're dealing with a binaural or bilateral hearing loss, then uncomfortable loudness levels will give you the information that the ABLB wouldn't be suitable for. So you need to pick and choose according to your case individually, I think, for sure.
Excellent. And I think that's rounded off those questions very nicely. So again, thanks very much for a fantastic webinar, Amanda, and I think we can bring that to a close.
Thanks very much. Thanks for listening, everybody.